My name is Dr. Suleman Khan. I'm the head of the Division of Rheumatology at Ledley Reading Hospital, Peshawar. Today, the title of my topic is Corticosteroids, or bread and butter. As you all know that we use corticosteroids quite a lot, so today I thought that we need to elaborate a little bit into this important area of our treatment options. So, first glucocorticoid was isolated, was the endogenous one, and this was cortisone back in 1935. Cortisone was synthesized in 1944, and it was called compound E. First, it was used by a gentleman, an American physician, Philip Hinch, in 1948, for which he was given a Nobel Prize for that in 1950. And as you can see in this slide, there is quite a lot of benefits of corticosteroids, but at the same time, you can also see the bottom of the slide where there is a lot of side effects that we need to be aware of. So it's really important to keep this in mind because these medications not only help us therapeutically, but we need to be aware of the potential hazards of these important medications. There's different types of glucocorticosteroids, as you can see in this slide: hydrocortisone, prednisolone, methylprednisolone, triamcinolone, dexamethasone, betamethasone, and fludrocortisone. And we need to be aware of their basics as well at the same time. So the mechanism of action is either through genomic mechanism if the dose is low, and non-genomic mechanisms if we are using these in higher doses. The question really is that how much of the steroid we should use, and it really depends on the type of diagnosis, the organ involvement in a particular condition, and how emergent the problem is really. And then we need to be aware of the cellular mechanism of different glucocorticoids. We need to be aware of all the wanted and unwanted clinical effects. The timing as well, as I mentioned, minimum and maximum doses, and what are the potential alternatives to glucocorticoids if we are dealing with a patient in a particular situation. So we need to be aware that the different strengths that we use, low dose is generally regarded as dose of less than 7.5 milligrams of prednisolone. The medium would be somewhere between 7.5 to 30 milligrams, and more than 30 milligrams up to 100 milligrams is regarded as high dose, and very high dose is regarded as more than 100 milligrams. Then there is pulse therapy as well. More than 250 milligrams of prednisolone equivalent is regarded as pulse therapy. There is so many different conditions that we use steroids in, and you are aware that rheumatoid, lupus, vasculitis, dermatomyositis, PMR, GCA, vasculitis of different types, connective tissue disorders, and inflammatory arthropathies, and even in tiny little doses in inflammatory OA of the hands as well. Steroids are used, but there are definitely more other conditions that we would use glucocorticoids in. In terms of the different conditions that we use glucocorticoids in, I have briefly touched rheumatoid arthritis here because of shortage of time. But a review of 7 studies showed glucocorticoids can be used for 6 months in rheumatoid arthritis, although my own tendency is to use it for a brief amount of time and certainly establish our patients on disease-modifying anti-rheumatic drugs. But there is definite evidence that this decreases the joint damage, reduces radiographic progression, and in low doses, these medications are efficacious in suppressing clinical disease activity and improving functional ability, so quite useful in that sense. In a double-blind RCT, patients with established rheumatoid arthritis, low-dose prednisolone, when added to existing DMARD, treatment in patients with active disease had a significant effect on disease activity scores and HAQ scores. And here you can see the reference. The clear consensus, however, regarding the dose and tapering of glucocorticoids is still lacking. There is new data which is suggesting that short-term lower doses of glucocorticoids starting at 30 milligrams or even slightly lower per day with rapid tapering, as in Cobra Light regime, might be feasible alternative to higher doses starting at 60 milligrams. As you are all aware, in rheumatoid arthritis, we would be using lower doses rather than 60 milligrams, but this is just a historical statement that they have mentioned in ARD online first. You need to be aware of this term called GILS. GILS is basically glucocorticoid-induced leucine zipper, which is an anti-inflammatory protein which is upregulated by glucocorticoids. GILS is increased in peripheral blood of rheumatoid arthritis patients and even more so in patients taking prednisolone. Measuring GILS inducibility in response to steroid, prednisolone, may be a useful way to determine which patients are likely to experience significant improvement in their disease activity with relatively low doses of corticosteroids. So this is now personalized, modernized medicine where patients will be assessed in regard to the response to different molecules or medications that we'll be using for their treatment. And obviously steroid is one of them. So GILS is important in that perspective. And hopefully this should be used this will be used in future to determine the response to steroids in RA patients. Now, what is pulse therapy? Pulse therapy, as we said, that if the dose is more than 250 milligrams of prednisolone, it is regarded as pulse therapy. And this is used in remission induction, treatment of flares, and prevention of complication in RMDs, for example, visual loss in giant cell arthritis. And there is quite a bit of importance of pulse therapy because when we start our patients on different immunosuppressives, we need immediate sort of effect, and that only can be achieved through pulse therapy of glucocorticoids rather than waiting for rituximab or cyclophosphamide or other immunosuppressives to show their beneficial effects. So the dose usually of pulse therapy varies from 500 to 1000 milligrams per day for 1 to several days. We in rheumatology here use up to 3 days, but some of our neurology colleagues would use full dose up to 1 gram or 1000 milligrams for 5 days in certain neurological conditions. And likewise, probably the nephrologists use it in higher doses as well. It really depends on the situation and the condition of the patient. The duration of effect of pulse therapy is up to 6 weeks. So you can expect good results and a reasonable control for up to 6 weeks. But beyond that, obviously, you need to establish your patient on appropriate immunosuppressives. The adverse effects of pulse therapy include osteonecrosis and psychosis that you need to be aware of, apart from other side effects that I'll be touching on later on during this presentation. But at the same time, when we come across patients who have pregnancy and who are lactating moms, patients who have infections, peptic ulcer disease, glaucoma, uncontrolled hypertension, and diabetes mellitus, you must use these medications with absolute caution. And there are obviously relative contraindications in these circumstances. If the benefit outweighs the risks, then you certainly can decide the use of these medications, but that's a clinical decision. However, having said that, you need to be aware of these conditions that you need to be careful about. Now, we have come across patients, and I'm sure in your clinics, you do see patients who will be seen by other specialties and other colleagues from different areas. Unfortunately, as there are not many rheumatologists and people who have expertise with corticosteroids, although these are used quite extensively, At times we come across patients in whom other physicians or surgeons would have used steroids for pain relief. Now there is no evidence of that, and this study of 3,887 references retrieved by Systemic Literature Review, 2 randomized controlled studies and 35 review articles underwent a full text review. And the conclusion was that no data on the efficacy and safety of systemic corticosteroids in residual pain could be identified from the literature. So please do not use steroids just to treat pain. Your patient could have pain due to degenerative problem, due to fibromyalgia, due to chronic pain, due to fatigue syndromes. And it's not necessarily always inflammation which is causing pain. Nevertheless, even if it is inflammation, you need to look into the problem exactly and escalate the treatment and give the treatment accordingly, and just do not purely rely on corticosteroids to help with the pain. Tapering is an important aspect of our treatment, and if it is not done appropriately, then definitely it will result in a lot of side effects. So the dose de-escalation or decrements of 5 to 10 milligrams every 1 to 2 weeks when prednisolone dose is higher than 40 milligrams per day should be used. 5 milligrams every 1 to 2 weeks reduction at doses between 40 and 20 milligrams per day, and likewise 1 to 2.5 milligram per day decrements every 2 to 3 weeks at prednisolone dose of less than 20 milligrams per day. But you will need to follow up, you will need to have a good follow-up of your patient, and you can decide accordingly. This is just a guidance and does not really holds its ground for every single patient that you'll be coming across. So regular follow-up and seeing your patient from time to time to decide how effective or how reasonable your decrements of steroid dose is. Pregnancy is one of the most important areas, and lactation, and we come across young ladies who will have gestational situation, and they might be lactating as well, because as you are aware that rheumatic diseases are quite common in young ladies. So we must be aware of this. Even the most well-established antenatal steroid therapies, however, lack the comprehensive pharmacokinetic and dose response data necessary to optimize dosing regimens. Pregnancy, as you are aware, is a natural protection against certain of these RMDs. And the protein-bound glucocorticoids cannot cross the placenta, out of which prednisolone, methylprednisolone are good. In the first trimester, avoid high doses. Low to medium doses are perfectly fine. They're safe. Lactation is safe for mothers who are taking glucocorticoids. Mothers should feed their babies before their daily doses. And the other option is to avoid lactation during the first 4 hours after the intake of prednisolone. In pregnancy, the incidence of infection with doses lower than 10 milligrams is quite reassuring. Screening for gestational diabetes should be done at 16 and 28 weeks, as these medications can cause glucose intolerance and steroid-induced diabetes mellitus if they're using higher doses, more than 10 milligrams. If the patient is requiring a dose of more than 10 milligrams, then make sure that they are on appropriate disease-modifying drugs, but make sure that those medications are not contraindicated in pregnancy or lactation. Hydroxychloroquine, sulfasalazine, azathioprine, tacrolimus are certain of these DMARDs, but TNFs have got safety profile as well, particularly cetolizumab can be used during these conditions. High-dose steroids should not be withheld in women with uncontrolled disease activity. In our clinics, we come across patients who need frequent injections, but you need to be aware that even if it is an inflammatory condition, and if the joint is particularly inflamed, or even if it is a soft tissue injection, you cannot repeat it within 3 weeks, and in weight-bearing joints, not more frequently than 3 times a year. I personally feel that if the patient is requiring quite frequent intraarticular or soft tissue injections, you need to sort them out otherwise, because that is not the long-term option, and steroids might cause more harms than benefit in those patients. So in comparison between intra-articular steroid injection and placebo, the evidence for efficacy was detected for pain and patient global assessment improvement at week 1, and then at week 2 and weeks 3 post-injection. But this was more in the inflammatory arthropathy kind of situation. When it comes to osteoarthritis, there is, however, some justification for the use of intra-articular corticosteroid therapy in selected patients only, because if your patient has got quite marked degeneration in their joints, there is no point in injecting steroids in those joints. The best thing would be to refer them to orthopedics for knee replacement. Injectable corticosteroids in soft tissues, for example, injecting lateral epicondylosis should be discouraged. It really doesn't help much, and there is some studies suggesting that the effects of physiotherapy is far more better and far lasting than just injections. And likewise for these other enthesopathies as well. Using image guidance, however, is quite good if you are injecting, for example, a subacromial bursa. If you do an ultrasound guided injection, it is thought to be more effective as well. So when it comes to steroids, the picture is good when we expect something good out of the efficacy. We do get a lot of good effects of steroids, but there are hazards at the same time as well. And glucose intolerance, as I briefly touched in the pregnancy section, is more witnessed if the patient is taking more than 10 milligrams of prednisolone per day. Likewise, osteonecrosis, more than 20 milligrams per day. These patients can have cataracts at doses as low as 5 milligrams per day. And also glaucoma if the dose is 10 milligrams per day. These doses are just from the literature, but you nevertheless, sometimes at higher doses or even lower doses, they can have these side effects. They can become Cushingoid with doses more than 7.5 milligrams per day. And obviously there are risk of infections as well as osteoporosis. So from epidemiological studies, treatment with a daily dose of less than 10 milligrams, there is not much risk of infection, or rather minimal, but with doses between 20 and 40 milligrams and higher doses, the risk of infection definitely increases. People with RMDs are at high risk of infection because they might be on other medications apart from steroids, and they should be vaccinated for influenza and 23-valent polysaccharide pneumococcal vaccine. Inactivated vaccine are fine, but their efficacy might be reduced as these patients would be on other immunosuppressives as well. Live vaccines are generally contraindicated under immunosuppressive therapy owing to safety concerns. The risk of infection depends on age, dose, duration, and presence of comorbidities. In case high doses are required, prophylactic measures must be taken. So here's a beautiful picture which shows that glucocorticoids do cause osteoporosis through all those different pathways. Glucocorticoids actually reduce bone mass, reduce bone strength, and then if the patient becomes osteoporotic, the risk of fracture increases. How to prevent this? You need to have the fracture risk assessment scoring done from time to time, particularly in those patients who are taking steroids at a dose higher than 7.5 milligrams per day. Please do check their vitamin D, calcium, and consider bisphosphonate, denosumab, and teriparatide treatment depending upon the patient, and you can individualize these treatments accordingly, but they definitely would need treatment. So glucose intolerance and diabetes, in one case study, in non-diabetic individual, the odd ratio of 1.8 was witnessed. If patient is taking 10 milligrams per day or less, the risk and odd ratio increase with increasing the doses of glucocorticoids. But you need to be aware of postprandial hyperglycemia and other conditions at the same time. Improving therapeutic ratio of glucocorticoids, you can think of modified release prednisolone, alternate day regimes, and selective corticosteroid receptor agonists. Here is the different names of the new molecules that we'll be using hopefully in future. Now, there is resistance of these medications as well. At times you give steroids, but the patient is not responding. So there is a lot different mechanism. I don't want to spend too much time on these, but you need to be aware that this does not mean that your patient not being responsive to glucocorticoids does not have inflammatory condition. So this needs to be kept in mind. And how to overcome adverse effects and resistance. You can use new delivery vehicles of different liposomes and scaffolds and different other things that have been mentioned here. Really, you need to be aware that you need to have a chest x-ray and different screening tests before you embark on starting your patients on high-dose steroids in particular. So the take-home message here is that corticosteroids have huge benefits when it comes to controlling disease activity and inflammation, particularly in acute settings. But we need to be aware of all the associated hazards and side effects, and therefore use them judiciously in all our patients. Thank you very much.